Hi everyone, welcome to our lesson today. Last week we talked about um, ischemia and infarctions, and we learned that ST segments and T waves play into a big understanding of what all that is. We had ST elevation, meant that there was a STEMI or a myocardial infarction, and then we had some ST segment depression that mimicked ischemia, so that was just the narrowing of the blood vessels. So there's a little bit more to understand. Just when you thought you knew it all, yeah, we're going to throw you a curveball and throw a few more things in there. Okay. So a little bit more on understanding ST segments and T waves is what we're talking about today. So let's just get right into it. All right. So there's other causes for ST elevation. I know it can't just be simple, right? There's another cause for it. Could this possibly be normal? It is actually occasionally normal in some patients. Yes, it is. Especially young patients, super athletes. It's called early repolarization, and we'll talk about that. There's also acute pericarditis. So someone having an inflammation or infection in the pericardium, that sac that surrounds the heart, can have symptoms very similar to a heart attack. They will have chest pain, they'll have some shortness of breath. It's an inflammation or infection in there, so it's going to hurt and it'll be a little bit inflamed. So that can mimic a heart attack as well. Something called early repolarization. So if you're that depolarization and repolarization that happens in the heart, where the heart muscle swaps the ions and contracts and then goes back, it can do that early, and because it goes early, it doesn't get a chance to make it back to the isoelectric line in that QRS, so it shows up just a little bit above it. That's what early ripple is called. Of course, there's pulmonary embolisms. There's something called Brugada syndrome. Any patients that have hyperthermia or hypothermia, and then there's trauma cases too. So all of these can cause actual ST elevation as well. So lots of things to look at. It's not always a heart attack. Okay, so let's take a look at some more of these. All right, so let's get into normal ST elevation. That's normal? What do you mean that's normal? So a normal ST elevation of 1 millimeter or more. So that's a little teeny tiny box, okay? If it's just a little bit above the isoelectric line, and it's seen in these young active males, typically age 17 to 25, will have this early repole here. Okay, so it's pictured down here in this. Why is my mouse moving over? I apologize. My mouse does not want to move over there. There it is. All right, so these that are circled here is an indication of early repolarization in young males. They did a study of like 6,000 young males that were in the Air Force, and 91% of these men, that is a lot of them, had marked ST elevation. It typically affects leads V1 through V4. Okay, so these are young athletes that are running a lot. In boot camp, they run and they exercise and do the ropes courses and all kinds of other stuff. So they're very active. I do see this a lot in my teenagers here at the school. So those juniors and seniors that are basketball players, sprinters, jumpers, runners are going to have this ST elevation that mimics what looks like ST elevation. It's really just early repole or normal for them. Okay, so it is normal if they're young and athletic. Hopefully that makes sense. I don't typically see this in the young females. Okay. All right, so pericarditis obviously is the inflammation of the pericardium. The symptoms do mimic an MI with ST elevation. So you will see ST elevation on the EKG. Okay, they'll have some chest pain or pressure, some shortness of breath, some palpitations. They typically feel weakness and fatigue, all symptoms of a heart attack, right? Yes. Again, we see this more in younger patients. So I don't see pericarditis as often in like the 60 and above range, but I do see it in that 30, late 20s, early 30s up to 40 aged people that have pericarditis that feel like they're having a heart attack but aren't really having one. Okay. You'll still see some changes on the EKG occasionally here. You can see it looks very funky here. Some ST elevation here in these leads, in these anterior leads, specifically the anterior leads. Okay. And the only way to check that is we're going to do a couple things. We do the EKG first. It looks like ST elevation. We're going to pull some troponins to see if there's anything going on with the troponins, and we'll take it from there. We take age into consideration, what's happening, their family history, and all that as well. We learned that also in the last lesson. All right, so here's the early repull. So early repull is when those potassium ions have swapped places, and they do it prematurely. And it's typically, again, in young adolescents, especially young males, those that are active jumpers, runners, sprinters. I guarantee, like if we did the NFL football team, the young athletes on there would have this early repolarization, okay? It presents again as ST elevation on the EKG. So it's like, what do we do? Now we have all these different things that ST elevation could be. You have to start putting the clues together. Remember the age we talked about, their symptoms, the history behind all of this. Why are they feeling this way? What were they doing when they felt this way? We can do some chest x-rays, the troponin levels. We can really just dig into it a little bit deeper. Okay, it's typically seen in all the leads, but more often in the anterior and lateral leads for the early repull. It's also called something called a J wave or Osborn wave. And it's this little bloop. It's really kind of a cool looking thing. It's this little badoop badoop right there. Yes, that's a scientific term, badoop badoop. It is. Yes, it's my scientific term for it. Badoop badoop. Yeah. This little thing right here. Notice that the QRS comes up and then it does this badoop and comes back up. This is a 100% indication this is early repull. Okay. So it repolarized early. Those ions swapped early before it hit the isoelectric line and was able to go straight across. Okay. They can slur the QRS a little bit too. And there's a little badoop badoop right there. This is kind of a badoop badoop. It's called the J point. It's called a J wave because the J point, as you know, is where that isoelectric line meets the S wave, right? That J point there. So it's called a J wave because it has a little wave where the J is, the J point is. Okay, it's also called an Osborn wave. So early repull, very common, athletes, younger males. Don't see it so much in females. It's more the male population. All right, let's keep going. So here's an actual example of what it looks like, the classic repolarization right here. So where it's ST elevation and the J point is right there. This is repolarization there. And then J wave is going to be in this one. And you can see the J wave right there. So this is it without the J wave, and this is it with the J wave. Okay, the little badoop badoop. Yep, that's what I said. This one's called a slurred QRS. You can see the QRS, and then instead of meeting the isoelectric line immediately, it slurs its way down, kind of like a little ski slope. Okay, so that's also considered repolarization. And then this one right here, the J wave or J point in elevation. It's actually on the isoelectric line, but you can see the little badoop badoop there. Okay, my very scientific word for it, badoop badoop. Yep, the woohoo badoop badoop. Yes. So this is what classic repolarization looks like. It is ST elevation, just like we know it. It looks like ST elevation. Yeah, and so it's hard to tell, except that if it's an 18-year-old that has this, it's probably not a heart attack, right? That makes sense. And then this is the ST elevation with the J wave, the little badoop badoop. You can also have one that's slurred, just as a recap here, and then you can have the badoop badoop without the elevation, which is considered still a J wave or J point elevation. All signs of early repolarization. Okay, they are easier to find on the EKG than you think. So hopefully we'll look at some a little bit later. All right, let's keep going. All right, so LVH, this stands for left ventricular hypertrophy. It is an enlargement of the left ventricle, like a thickening of the muscle wall, right? Lots of different causes for this, okay? Someone who's older, it's going to be probably chronic hypertension. So they've had hypertension for a while, gone unnoticed or untreated, and it makes their left ventricle enlarged, okay? It's kind of bad for someone older to have chronic hypertension and to have their left ventricle enlarged. That's a bad LVH, okay? There is athletic hypertrophy. So this is related to exercise. Someone like a marathon runner, soccer player would have athletic hypertrophy. So their left ventricle is enlarged in a good way. So it pumps blood faster and harder for them to be able to run longer and faster, right? It can also be caused by a congenital disease. Obviously, that's not wonderful if that's caused by congenital. Sometimes they might need surgery or even a heart transplant because of it. It doesn't work properly. If you think of an enlarged muscle, obviously, like if you work out and you get your biceps nice and big and strong and you can lift things heavy, that's a good workout, enlarged muscle, right? So think of the dude that works out in the gym way too long. He gets so big and muscly, right, that he can barely move, like he has to walk sideways through the door, right? His muscles are so large that they're stiff. They won't even contract the right way. He doesn't have any flexibility. So that's a bad LVH, is when that heart muscle is so enlarged it can't squeeze like it's supposed to. Okay, that's the difference between good and bad, right? It can also be caused by cardiomyopathy, any subclinic valve disease, and then in kids, it's normal, completely normal for kids to have an LVH, a large ventricular or enlarged left ventricular hypertrophy. Basically, little kids are athletes. They run around all day, right? Their hearts are brand new. It's nice and strong. Pumps really great. You know, they're running around being themselves. They're little athletes running around, which is awesome. If you have kids or have siblings or nieces and nephews that are small, you know exactly what I'm talking about. Yeah. So how does that present on the EKG? It makes the QRS look very large. Okay, let's take a look at that. So here is an EKG of an athlete. And take a look at these QRSs. They are humongous. Let's see if I can move my face a little bit more. So they are humongous. They're so big they run into each other on the paper. You see that? They're running into each other. So this is an athlete. You can see some of the early repole, a little bit elevation, and these huge QRSs. Remember that QRS represents those ventricles squeezing. So if it's squeezing hard because it's atrophied or it's hypertrophied, not atrophied, that's opposite, hypertrophy, then it's going to be a really big QRS. And sometimes it goes right off the paper and it runs into the next one. So this is an example of what would look like for an athlete. I would circle these big QRSs and let that be known that this is just huge for an athlete. Okay. All right, next one. This is LVH for a 3-year-old. So look at this 3-year-old's EKG. This is a pretty interesting EKG. It looks different than the ones we're used to looking at, isn't it? Yeah. And it's different because, number one, the QRS is shaped a little different. It is super narrow. It's super duper narrow. It's definitely less than that 0.08 that we are used to looking at. It's super narrow and it's super large. So this is a 3-year-old EKG. Other things that you might notice is that it's going a little bit faster, right? This EKG is, let's see, heart rate 300 is about 150. So 150, it's a little high for a 3-year-old, but it's they could have just been running around the yard, you know. And then they have all of these really big QRSs. They're tall and they're skinny. The other thing that's noticeable that you probably are noticing right now is that their EKG, their T waves, typically in V1, 2, and 3, are turned over. They're flipped upside down. So they have inverted T waves. As they mature and get older, they start to flip over. And occasionally, you'll still see a flipped T in V1 in females the rest of their life, or just occasionally, just never fixes itself for whatever reason. So this is a healthy 3-year-old EKG. Different than what you and I look like. Okay, so here is an LVH for a 60-year-old. Okay, so LVH for a 60-year-old. So this is bad, right? This means that they've had chronic high blood pressure typically. They have very large QRSs and ST depression happening here. Okay, big QRSs, ST depression. I know it's ST depression because I see the T wave right after it. It's a little T wave, but it is there. So when we see big QRSs, specifically down near the left ventricle, which would be V4, 5, and 6, right? That's down in our armpit, kind of near the left ventricle there. We see really big QRSs, and anything that happens inferiorly, then we know that they have LVH. And again, it's typically caused, in a 60-year-old, it's typically caused by chronic hypertension that was not treated. Okay. All right. Let's talk about embolisms, pulmonary embolisms. If at any time I'm going too fast, obviously just pause, rewind, go back and look, check it all out, re-listen to what I say. I always feel like I'm going fast. We'll see. We'll see. I have a break built into this one, so a break will be happening here pretty soon. All right, so pulmonary embolisms, as you know, pulmonary means lungs. An embolism is when one or more arteries in the lungs are blocked with a blood clot. Okay, so if you get blood clots in your arteries in your lungs, we're having an issue. It's called a pulmonary embolism. So my respiratory therapists probably know this stuff pretty well. So symptoms mimic what happens when you have a heart attack: shortness of breath and chest pain. It's in the lungs, which are right on the other side of the heart, so you feel pain in there. It's hard to breathe because you have blockages in your lungs. So obviously that's going to mean you're going to have some shortness of breath. Okay. Now the EKG changes that we see for pulmonary embolism, typically they'll be a little bit tachycardic. Okay. Having a hard time breathing, almost hyperventilating sometimes, so their heart rate shoots up. That makes sense, right? We also are going to notice some deeply inverted T waves. And there'll be some small ST elevation here and there. So their T waves aren't going to be the little tiny ones. They're going to be deeply inverted. Okay. Then they follow this formula. So this is almost identical to what, or not identical, but it's a tell-all that there's a pulmonary embolism going on. Okay. So in in lead one, the S wave in lead one, I'm saying it wrong. The acronym you use is S1Q3T3, right? So the S wave in lead one, remember QRS, the Q wave in lead three, Q, it's going to be the first Q, and the inverted, you'll see an inverted T wave in lead three. Okay, so let's take a better look at it. We'll take a look at the EKG. Just write down this cute little thing that you're supposed to remember. That will help you when you look at it. All right, let's take a look at it. So when you're taking a look at it here, the S wave up here is going to be very prominent, very deep, a deep S wave in lead one. Sometimes our S wave is flat and you don't even barely see it. We have a QRS, right? S usually is up here by the isoelectric line. This S is going to be very deep. Your Q wave in lead three, so we're going to down Q3, lead three, down at the bottom here. Your Q wave is also going to be deep. So a large Q wave, a large S wave in one, a large Q wave in three. And then you'll also see an inverted T wave in lead three. So this formula, the S1Q3T3, refers to the leads, not the leads, the QRS complex. So our complexes that we're looking at are waveforms. So S1 refers to the S wave in lead one is going to be large and deep. Q3 refers to the Q wave in lead three will also be large and deep. And then the T wave in lead three, so there's two things happening in lead three. You'll see inverted T waves in lead three. This explains it really well here. So S waves in lead one are going to be deep. Q waves in lead three will be deep, and inverted T waves in lead three will also happen. And there's some sort of announcement happening. Exciting. Sorry about that, guys. If I pause, it stops my whole video. So. If you are in a stairwell or the hallway and you are unsupervised, they are kicking them out. Exit the building at this time. And then we'll be making their way through the building, and if you are caught unsupervised, you will receive a consequence. I am supervised. You guys are supervised. You're waiting on a ride. You must go to the breezeway located in the main lobby. All right, let's talk more about all students must be within a pulmonary embolism. That includes you two in the back stairwell in the end hallway. All right, this one right here, she's getting her point across. All right, this one right here is a classic pulmonary embolism. And all we need to look at is lead one and lead three to tell. So remember, S1 is going to be lead one, and we're going to look at the S wave. Look how large and deep this S wave is, very deep. That doesn't mean that every S wave in lead one means pulmonary embolism. You have to have all three criteria, okay? So I see a very large S wave in lead 1. I see that right away. I'm like, maybe I should check out the other ones. So go down to the Q wave. We're looking in lead 3. Q3 is the Q wave. And this one is also large and deep. And our last piece of the puzzle is the T3, is the T wave in lead 3, which is right here. It's inverted. This tells me that it is a pulmonary embolism. We also notice that it's tachycardic, right? So that also gives us another clue. So there's 4 clues there that this is probably a pulmonary embolism and not a heart attack. So we would go forward with an chest x-ray and take a look at the lungs and see if this is what, it's a pretty good indication right away without having to do an x-ray. Just do a quick little 5-minute EKG and we're like, wow, I think they have a pulmonary embolism. The faster we get to it, the faster these people are going to be safe and, and they can do whatever they need to do to rectify that, okay? So tachycardic also is 300, 151, it's about 120, 125. All right, pause again if you're not quite sure and go back and watch. All right, so Brugada syndrome, I actually have a friend with this. It is a condition that causes a disruption of the heart's normal rhythm. It looks weird, okay? It can lead to other things. It's usually the first sign before you have something else, like an irregular heartbeat, like if you pass out. You can have seizures, breathing, even sudden death. My friend was freaked out when he heard this. It's like, it's rare that it's going to be sudden death. But it typically comes in adults, but it can be throughout life. It's typically like 30s to 40s is where it shows up. So sudden death occurs most commonly around age 40 if it's going to happen. It's not the most common thing with Brugada syndrome, but it does show up on the EKG very oddly, okay? It's easily diagnosed. They just need an EKG, okay? And then some genetic testing as well if needed. So it looks like a very weird looking ST elevation. They call it a saddlebag because it's elevated and then it sags down like this. And we'll look at it. It typically presents in D1 through 3. We're going to take a look at it in the next slide here. It shows you what it actually looks like. And there's a couple different formations of that. But this is what Brugada is. Okay. All right, so type 1 Brugada is where you see this elevation and then we have this weird downsloping here. Okay, it looks different than a regular ST elevation. And then type 2 and 3, you're going to start to see the saddlebags here, where it's a little bit elevated and then it sags. So it doesn't go straight across like our other elevation we've looked at, and it sags down. So it's not straight across like we've seen in the fireman's hats. It's not like a fireman's hat. It has this saggy part to it. It slopes down. Okay, in 2 and 3. This is a little less identifiable than these two. If I'm going to put anything on a test, I'd probably put one of these two on with a definite saddlebag look. Okay, but that's Brugada. My friend that has it has no symptoms, had no idea he had it until he had an EKG done routinely. He is currently 39 years old. So it's good they caught it because the sudden death thing, if it were to happen, even though it's rare, happens around that age. So it's good that they caught it. Yeah, no definite lifestyle changes for him. He's actually very active. We just need, if he has no symptoms. So if he has any symptoms, he's supposed to let his doctor know. All right, so this is interesting too. So hyperthermia and hypothermia, typically it's hard to find this sort of stuff, or hard to read the EKG because they're shivering, right? It's hard. So they have to lay still, otherwise we get that muscular artifact. But in both hypo and hyper, there is the J wave. You'll see the J wave or Osborne wave. And their heart rate is going to be, especially in hypothermia, their heart rate decreases tremendously. Okay, so hypothermia, their body processes have slowed down. Their body's super cold. Okay, and they're shivering, so it's hard to get the EKG. You might see some artifact like this. This is a very slow heart rate, 1, 2, 3, 4, 5 times 6 is only 30 beats per minute. And you can see the J wave here, the Osborne J wave in these leads, and here too. It's that little boom-ba-doom, right? The J wave or the Osborne wave is a little boom boom right after. It mimics ST elevation, but it can be caused by hypothermia, believe it or not. Yeah. So once we warm the patient up, we get their blood pumping a little bit better, the heart recovers from that, then the J wave typically goes away. All right, last one we'll talk about for ST elevation is trauma. So trauma can be caused by any type of huge damage you might have to the heart. So a car accident where the seatbelt hits you or the airbag hits you in the chest, that can cause it. You can actually get hit by a baseball bat, a baseball, hockey pucks. This is whenever someone comes in from having a car accident, some sort of trauma, they order an EKG. They want to make sure that the heart didn't receive any trauma. So it's going to, since it is a trauma to the heart, just like we learned last class, your troponin levels will actually be elevated because it's some sort of trauma. It doesn't necessarily have to be a heart attack. It can be any sort of blow to the chest. Okay, so they're typically elevated. The troponins are elevated. We might see ST elevation. They might be tachycardic, some sort of arrhythmias. It can hit the heart so hard that it can, like a shock, knock it out of rhythm. Okay, the football player recently that went into cardiac arrest on the football field got hit to the chest with a helmet so hard that it stopped his heart, and he went into cardiac arrest. So if it's hit just right, it can knock it right out. Crazy. I know. It's like a shock, basically. So they will do further testing. They do what's typically called a TEE. So my sonography people know this. My echo techs. A TEE is where they place a probe down your throat. They usually sedate the patient, put the probe down the throat, and they can look at the heart through the esophagus, since it sits next to the heart technically. You can look at it that way, just a cooler way to look at it inside. You can see the valves open and close really well, which is what they're looking at, and to make sure the ventricles are squeezing appropriately. All right, so I have a break worked in here. Here is your break time. So if you'd like to pause the moment, pause right now and take a break. We'll start up in a little bit. I'm going to pause. I'm not going to pause. I'm going to keep going. So welcome back if you came back. If you took your pause and break, welcome back. Here we are. Let's talk about T waves. We are back for T waves, okay? T waves. We learned about T waves. We learned about peak T's and inverted T's last class. What about them? Let's see. There's some few things we need to know about these T waves, okay? So we know that, number one, my face is in the way. Not so bad. Okay. We know, number one, that peak T's can actually mean an acute MI. Acute meaning it's happening now, okay? And we looked at that little chart, how it transformed from being a regular EKG into a heart attack into a STEMI. And this is one of the phases, right? So it's just starting out when we see the peak T. Okay? A peak T, if you recall, is a really tall one that looks kind of like a tent or a teepee or the Eiffel Tower. Okay? So it can be an acute MI. It's happening right now. Inverted T's actually typically meant a recent MI, also meant ischemia, but can mean a recent MI, meaning it just happened yesterday or 2 days ago. So in the winter months, we see when we first get our first snow, patients will be shoveling snow and they get chest pain and they stop and rest for 10-15 minutes. Chest pain goes away, they finish shoveling, and then 2 days later, they're like, you know what? I still don't feel very good after I had this chest pain the other day. I better go get checked out. I get them hooked up to the EKG machine and I see these deeply inverted T's. So inverted T's like this that are deep, the more deep they are, the more recent an MI. So this is telling me this guy had a heart attack when he was having that chest pain at home while he was shoveling. Didn't go to the hospital, didn't do any of that. This happens a lot, by the way. They come in, we hooked them up, they've already had a heart attack. Yeah. All right, so what other instances can we use these for? Let's see if I can move this just a tiny bit. I want to make sure you guys can see everything I have on the screen for you. All right, so peak T's can also mean hyperkalemia. So hyperkalemia, you've probably heard the word before. If you're thinking in your brain right now, you're like, what does that mean? K in chemistry Think about what K in chemistry means. Did you say potassium? You're correct. K in chemistry is potassium. So hyperkalemia is elevated potassium levels. Okay. It can also mean ischemia. It can also mean a normal variant. What? How the heck do we tell the difference then, right? What the heck? How are we supposed to know? What's normal, what's hyperkalemia, what's ischemia? We're going to have to dig a little deeper. Okay, so let's go through this. So if it's an acute MI, you see peak T's on an EKG, they're going to have signs and symptoms that it's a heart attack. Okay, they're going to have the chest pain. They're going to have the shortness of breath. They're going to be diaphoretic, clammy, and gray. For women, it presents a little bit differently. We talked about it in class last time. They can present with back pain, shoulder pain, arm pain, abdomen pain, epigastric, dizzy. They just don't feel right. Okay. So any signs and symptoms of a heart attack, and if they are of the age of a heart attack patient, that's going to mean we're probably going to assume it's acute MI. Okay. Now hyperkalemia peak T's are often seen with patients that have a reason to have a high level of potassium, and this typically is linked to renal failure. So patients that are on dialysis typically have a little bit elevated troponins as well as hyperkalemia. So you might see some really peak T's on hyperkalemic patients, dialysis patients. Okay, that's very normal for them. How do we know for sure it's just hyperkalemia, not acute MI? We're going to test two things, troponins and potassium. Once we test those two things, we can make our conclusions from there. Okay. And a normal variant, here we go back with the healthy patients without any reasons to have hyperkalemia. Again, typically age-related. This is going to be more younger teens again, teenagers, those with the peak T's already. They already have a little bit of early repole. You'll see a peak T with it. Okay, so those young male athletes, we talked about the Air Force people, will have these normal variant peak T's. Okay. Again, if I'm going too fast, just slow down. You'll catch up eventually. Yeah, you can always pause and rewind. All right, so hypokalemia is going to present exactly the opposite of hyper. So our normal potassium level in our body should be 3.5 to 5.0. Okay, and so if it's less than 3.5, that's considered hypokalemia. It's used for repolarization, so it does affect the T wave, and then it forms something called a U wave. Okay, so it gives us an extra wave at the end, believe it or not. The U wave is very difficult to spot sometimes. The machine will do it more faster than I will. I don't typically notice a U wave. I think it's just some sort of artifact. It's so small, you don't really notice it. So it's a prolonged recovery phase. So prolonged repolarization. Okay, so it causes the repole to be a little bit delayed, if you will. Right? So common arrhythmias with hypokalemia are PVCs, AFib, and tachycardia. Your T waves are going to be flat. So in hyperkalemia, they were really tall. Hypo, they're going to be the opposite. They're going to be flat. So your T waves are going to be flat. It's going to be hard to see them, if you see them at all. And there might be a U wave. Okay, so if we follow the alphabet, P, Q, R, S, T, U would be right after the T wave. So if you see an extra wave there, it's going to be the U wave. Yeah, I know, right? So this is a T wave, flat T wave with a U wave after it, and this is an inverted T with a U wave after it. So it could present as both. That's what hypopotassium looks like. Okay, hyper is tall T waves, hypo is flat. That's really all you kind of need to know. And here we are with hyperkalemia. We talked about this. If it's greater than 5.0, that would be considered hyper. It's, again, used for repolarization, so it does affect the T wave. Our physiological effects or common effects with this are bradycardia, something called escapes. There's some AFibs, VFibs, first degree AV block. Again, it's also associated, this is the most common, with kidney damage or infusions of excessive amounts of potassium, extreme exercise. Have you heard of rhabdo before? myelitis. My daughter-in-law had rhabdo. She was in the hospital for almost a week. She took a spinning class. Yeah, unusual amounts, excessive amounts of potassium can actually throw off everything. She literally, her legs swelled up so big she couldn't walk. She was trying like stiff-legged. It was crazy. So the T waves will look tall and peaked. The P and R waves are going to be smaller. The P may even disappear. QRS might be a little bit wider. So how do we treat this? We give them sodium bicarb. It shifts the potassium back where it's supposed to go and kind of dumps some of the potassium out for us. We just neutralize it with sodium bicarb. Sounds easy enough, right? It took her several days. This can lead to renal failure. Her urine was brown. That's when she knew she needed to go to the hospital. She was asking me about it over the phone, and I was like, well, it's rare. So I'm like, I don't know. Maybe just, are you urinating? And she goes, well, I haven't gone pee this morning. And I said, well, urinate and see what color it is. She called me back. She says, it's brown. I said, you need to go to the hospital. It's crazy. All right, so this is kind of what it looks like. This is a small, normal amount up to 5. When we get to 7, it gets taller. Get to 8, it gets taller. You can see 10, 11. We're way too high here. It's totally messed up our whole system, right? We don't have any regular depolarization, repolarization. It's not happening properly at all. Up to 10 and 11 here, it starts to get pretty severe. And then 12 or more, the heart probably stops beating. We end up going into like VFib. Bad stuff. All right, so hypocalcemia. This is not potassium now. This is calcium. So low levels of calcium, we have our normal calcium is 9 to 11. If you have less than 9, it typically decreases the contraction. So the QRS and QT interval, the ST segment length changes. So our QT is going to elongate, and our ST segment is going to be depressed. Okay, it's a slight depression, but as soon as you see that elongated QT, look for some depression. Okay, as soon as you have QT elongated, so it's sometimes you don't see it with the naked eye really quickly. Like this is kind of what it looks like here, but your machine measures that. When we looked at the little things on top of our EKGs, your machine measures that QT. And if it falls out of our normal range, 0.36 to 0.44, up in the 500s, 550s, we've got a problem. Okay, that's an elongated QT. All right? And then the ST segment in that elongation should be a little bit depressed. It doesn't have to be super depressed like we looked at before, but somewhat depressed. Okay, those are the 2 indications of hypocalcemia. How do we confirm it's hypocalcemia? We do a blood test and see what their calcium level is. Period. That's it. Simple. Blood test. Figure it out. Give them more if they need it. Yep. I know. Simple. Then we have hypercalcemia. So anytime we have high levels of calcium, it's going to be above 11. That's going to increase our contraction. Does the opposite of what the hypo does. Therefore, the QRS and QT interval length changes. It actually gets shorter. So hypo, because it's slow, it's low. Hypo, slow, lengthens our QT, and hyper is fast, so it shortens our QT. QT interval is going to be shorter than normal. So it'd be less than 0.36. Okay? What do you do for this? Treat it however you treat hypercalcemia. No big deal. All right, so quick reference, this is kind of what they look like. It's normal. And then we have ischemia, hyperkalemia. Oops, I didn't mean to do that. My bad. You can see that these all look very similar. Ischemia and hyperkalemia look almost identical. So the only way really to tell if it's ischemia or hyperkalemia is to check the potassium, check the troponins, signs and symptoms, age, all that stuff that goes with it. And then the hypercalcemia, you'll see that close, real short T wave, short QT, and hypo, you'll see the really long one. It's going to be a T wave that's far away. Okay? Hopefully that's easy for you to understand. All right, so let's go through some examples. We're going to talk about some of these patients and see if we can come up with some sort of interpretation. So this is a 57-year-old male patient. He presents with chest pressure. He's diaphoretic. He has dyspnea, and the EKG is shown below. So what other further tests do we run, and what do we suspect is this diagnosis or interpretation? So let's break it down like we've been doing. So lead 1 and AVL go together. 1 and AVL. Do I see any changes in 1 and AVL? I believe you have these in your examples too. I'm going to look at my packet while you're looking at that real quick. 1 and AVL. Yes, you do. AVL. I'm going to pop that over here. Let's do that. It's going to make it a little easier. All right, here's your example. Let me help you with this. I got other stuff starting. Things I'll just do what it's doing. All right, here we go. So we're looking at this, right? And I'm looking at 1 in AVL, and I don't really see any changes in 1 in AVL. Nope, no changes. So don't worry about that. I'm gonna look at 2, 3 in AVF because those go together. This looks like it might be a little bit depressed here because my isoelectric line is here and it's a little bit depressed. Here I definitely have a change. There's a T-wave inversion. And over here, it looks like ST depression as well. So I do have changes in, looks like 3 of the leads. So if I have ST depression and or T-wave inversion in these 3, I'm going to say in the inferior, it's inferior, right, has ischemia. Most likely ischemia. Okay. So when I look over here, I'm going to look at V1, V2, V3, and V4. There's definitely some changes going on here. I can see ST elevation right there. And I know it's elevated because here's my isoelectric line, and this is way above it. Down here, I definitely have a peak T. See the peak T? And it's not quite elevated, but I have a peak T. Here it is elevated and peaked. And over here, we have another peak T. It's more than 2 boxes high. 1, 2, 3, 4 boxes high. And I can talk about V5 and V6 as well. Let's see. This is 2 boxes high, so that counts as a peak T, but this just has depression. So anteriorly, V1, 2, 3, and 4, anterior, we had a problem, right? This is an acute MI or STEMI. Okay. So what other tests would I run for this? If we think they're having a heart attack, what's the first one we check? Troponins, right? So we're going to check tropes. And look at the T waves. Are the T waves nice and peaked? They're actually huge, aren't they? These T waves are peaked. So I'm going to check it just because it's really peaked. I'm going to check for potassium. Now, if our tropes and potassium check out, our tropes are high and all that stuff, he's going to go straight to the cath lab. Okay? I would send him to the cath lab at this point. Just because he's having all the symptoms and he's having ST elevation, and if his tropes are really high. If he is having high potassium, we can treat that later. The heart attack's more life-threatening, right? Yeah. All right, so that's the diagnosis we would do for that. All right, let's take a look at the next one. Right here, the 17-year-old patient. So the 17-year-old patient presents for a regular family checkup, and the EKG, is attached below. He has no signs or symptoms. He's just there for a regular checkup. Okay, so 17-year-old for a regular checkup. 1 in AVL. Lateral region of the heart, perfectly normal. 2, 3 in AVF. I don't see anything in there either. That looks normal. Over here, though, I do have an inverted T in V1. Do I have an inverted T in V2? No. V3, starting to get a little peaked, but not inverted. V4, this one's pretty peaked. V5, are we at 2 boxes? Yeah, it's kind of 2 boxes. Is this 2 boxes? It's almost 2 boxes. We've got some peak T's. They're lower peak T's, but we've got some peak T's, right? So peak T's, and then we have one inverted T. So when you only have one inverted T, that's considered non-diagnostic. That's just his normal. Okay, it doesn't match with anything else. You don't have any inverted T's and any other anterior leads, V1 through 4, non-diagnostic. We do have these peak T's though, but he's 17. He has no symptoms. Probably an athlete. This is very normal. This is a normal EKG. Normal variant for a 17-year-old. Okay, that's a very normal variant. No big deal. Okay, no further testing needed at this point. All right, let's switch on over to, let's see, I have, the next patient is a 48-year-old female. So always get the age, the background, the reason for the test, everything like that. Okay, so this 48-year-old female wasn't feeling well during dialysis. There's one clue right there. During dialysis, an EKG was taken and shown below. What further testing would you request, and what is most likely the diagnosis and or your interpretation? We're not cardiologists, so we can't diagnose, but we can interpret. Okay, so when I'm looking here, 1 in AVL, nothing, right? 2, 3 in AVF, I see a regular PQRST. Over here in V1 looks normal. V2, now we're seeing that peak T, aren't we? Peak T again. There. Is this 2 boxes high? Almost 2 boxes high. We could almost count that one, but not in V5, V6. So we have definitely got something going on anteriorly. So she's got peak T's. So I'm going to write peak T's. Write it down here so you can see it. Peaked T's anterior. That's the anterior region of the heart. Peak T's. Peak T's can mean 2 things. Actually 3 things. Can mean ischemia, can mean an acute MI, can mean hyperkalemia, but based on how she's feeling and her history that she's a dialysis patient, we're probably going to check 2 things. I would check for tropes and potassium. And why do we check for both? Tropes because she wasn't feeling well, and peak T's can mean ischemia or a heart attack, right? But she is a dialysis patient, so potassium could be thrown off. That's pretty normal for potassium to be thrown off as well. So I'm going to check both, all right? And then I'm going to, make my conclusions from there. So I'm going to guess that she's probably just hyperkalemic. She doesn't have any signs of a heart attack per se. She just doesn't feel right. A lot of patients having dialysis don't feel right. So we're going to wait for the potassium and troponins to come back and see where we go from there. Okay, so that's really it. Most likely hyperkalemia. Most likely hyperkalemia. Again, if you're going too fast, slow down. You can go to the next one, pause, rewind, whatever you got to do. All right, so T-wave inversion. We're looking at example number 4. Oh, no, this is not sample number 4. Is this sample number 4? Oh, yes. All right. So T-wave inversion is completely normal in children and adolescents. The most common is V1, 2, and 3. And here's an EKG of a healthy 3-year-old below. I can come off, I think, off this. Yes, let me come off this here. Close down my... There we are. We did sample 1. We did that one already. We did 2. We did 3. And all right, so different T-wave inversions can be seen on EKGs of certain ages and stuff like that. So I have a T-wave inversion on my V1. It's not always there, but it does pop up occasionally. Again, it does happen to females, so it's common for me. It's not anything for me to worry about. Okay, and I showed this EKG to you earlier that this 3-year-old has these inversions in V1, V2, and V3. Completely normal for a 3-year-old to have the inversions, and T1, 2, and 3, no matter the gender. Okay. So as they get older, they'll start to flip over to the normal way. So V3 will flip over first, then V2, then V1, and occasionally V1 never flips over. Not a big deal if it's non-diagnostic, right? So just be aware of that. And we get another cute clue that's telling us this is a 3-year-old is those big skinny QRSs, right? The heart rate might be a little bit higher than normal too. 300, 150, it's a little over 100. So a little bit higher heart rate, big skinny QRSs, and the inverted T's all tell us this is a 3-year-old EKG. So you can tell the age of a person by their EKG, and sometimes even gender. Yes, it is true. Isn't that crazy? All right, so here's an adolescent EKG. So they are often peak T waves and or T wave inversions, as well as LVH. Again, they correct themselves as they get older. You can probably spot the peak T's down here. Here's peak 1, here's a peak 1, here's peak 1. Big QRSs mean LVH. Very common in adolescents. They're strong athletes or they're strong hearts. And they just have these peak T's because they're early repulse and strong. So I see these a lot in the male younger athletes. Really big tall T's, a little bit of elevation, big QRSs. A lot of EKGs like this in my school. Basketball players, runners, things like that. All right, so how do we tell the difference? This makes the most sense. First, you're going to check the age of the patient and then the reason for the EKG. So signs and symptoms. Why are they here having an EKG, right? So age is going to obviously tell us first and foremost, right, what's going on. And then the reason for the EKG. So if they have peaked inverted T's are usually abnormal when they have symptoms. If you find a peak T without symptoms and they have other reasons to assume illness, like renal failure, it's most likely hyperkalemia. If you find inverted or peak T's with symptoms, then other tests are performed, like troponins, potassium, even stress tests, to find out what's going on. So no symptoms, and it's a peak T, unless they're a young teenager, it's probably hyperkalemia. If they're a young teenager, it's normal. You find inverted or peak T's with symptoms, older person, symptoms happening, symptoms today, yesterday, 2 days ago, we're going to test troponins, potassium, and potentially a stress test if those troponin levels come back negative. Can't stress them if their heart's already had stress to it. We don't want to add more stress, so we won't do that again. We won't stress them after they've had some sort of damage to the heart, obviously. All right. So let's just practice. This is just practice now. This EKG, again, match them up by the regions of the heart. So 1 and AVL go together. 1 and AVL, 2, 3 and AVF. This is lateral. This is inferior. So our lateral region, there's actually a change going on here. Okay, can you see it? Yeah, it's ST elevation. So this is kind of a fireman's hat. It's a smaller fireman's hat, but it's a fireman's hat for sure. This is the isoelectric line, and this is definitely elevated. And this is elevated as well. This is the isoelectric line, and this is elevated. So we have a STEMI going on in the lateral region of the heart. You would write it just like that. A STEMI stands for ST elevation myocardial infarction, happening in the lateral region of the heart. Remember, this tells the doctor where they need to go look when they do a cardiac cath to try to figure out where the blockage is and if they can stent it. Okay. In 2, 3 and AVF, there's a little bit of depression happening here, and almost looks like digitalis. I don't know what that looks like from last class. That digoxin can cause that slurring, but if it's not digitalis, then it's definitely depression. So that makes sense. It's a reciprocal, right? Across the top, across the bottom. If one's elevated, the other one should be depressed. So V1 actually looks okay. V2, we got a problem though. V3, V4, we've got some more fireman's hats going on here. Really tall ones. So this is actually elevated and peaked. Elevated and peaked. So we are definitely having a STEMI also in the anterior. So there's 2 regions of the heart. This person's having an elevation. So having a STEMI. Okay. And then V5 and V6, you can see V5 is a little elevated, but V6 isn't. So that's non-diagnostic. It's just probably some residual from V4. So what do we do with this one? we number one need to take troponins, right? Troponins for sure. We could do potassium if we wanted to, but I'm pretty sure the peak T is not potassium. This is heart related as far as STEMI goes. It also depends on their signs and symptoms. But troponin levels most likely go straight to the cath lab, especially if those troponin levels are high. Okay? All right. How'd you do? Let's try the next one. Okay, start with 1 in AVL. 1 in AVL. What do you see there? Anything? There's no change in 1 in AVL. So if you said nothing, you are correct. 2, 3 in AVF. Starting to see a few changes here. Definitely seeing some T-wave inversion, a little bit of depression. A little bit of, it's minor, but it's there. There's some T-wave inversion and some depression. That means it is probably ischemia. Over here in lead 1, this T looks a little peaked, but it's not criteria for a peak T yet. It's not 2 boxes high. This one is 3 boxes high. This is definitely a peak T. This is definitely a peak T. This is depression with a peak T. Depression. We see some depression. We see some peak Ts. Okay. So there's a couple things that could be going on here. Remember what depression means? Depression means only one thing, ischemia. So we have some ischemia, which is narrowing of the blood vessels, which is better than a STEMI. So he's already ahead here. Okay. Peak Ts can mean 2 things though. Peak Ts can mean acute MI. So could be having a heart attack right now. Could mean hyperkalemia. We don't really know how old this patient is, so if it's a younger patient in their teens, this might be normal for them. We definitely need a little more information before we can make a full interpretation, and that's one of the first things the ED docs ask me. How old is this patient? I bring them an EKG and I'm like, 25-year-old male, chest pain, shortness of breath. So they know that if they see this early repull or these peak Ts, it's normal for that age group. So let's assume this is a 67-year-old person. Okay, with peak T is not normal. So we're going to check 2 things. In your brain, think about what those 2 things are. I'll reveal them in a moment. So if you said we're going to check for troponins, you are correct. Troponins, because we're afraid he's might having an acute MI. And if you said potassium, you are correct, because we have peak Ts, and that can be caused by hyperkalemia, and that is caused by high potassium. So we're checking those 2, and then we're going to go from there. So if we have troponins that are negative and just high potassium, we know how to fix it. We're just going to give them some more potassium. They might even still do a stress test just because if they had some symptoms. We are seeing a little bit of ischemia there, so like over here. So they might still do a stress test if the troponins come back negative. It's really up to the doc. Okay, hopefully you said that. Let me know if you have questions. Let's move on to the next one. Once again, go with 1 in AVL. What do you see in 1 in AVL? My face is in the way. 1 in AVL? No changes. You are correct. 2, 3 in AVF. Anything going on there? No changes. Now look at V1, 2, and 3, and then 4, 5, and 6. This should be pretty identifiable to you now. So take a look at the T waves. Take a look at the size and shape of the QRS. Can you tell what the patient is, or who the patient is, how old the patient is? So did you see the T wave inversions in V1, 2, and 3? T wave inversions. Mm-hmm. So in someone that's older, that could mean ischemia or recent MI, right? But what gives us away that this is probably not an old person is the size and shape of the QRSs. They are skinny, and very tall. So that typically means that this is a small child. And then we can take a look at the heart rate and see if the heart rate matches that. Let's see. 300, 150, 100, about 100. So yeah, this is definitely an EKG of a smaller person. And in that case, this LVH we're seeing, large QRSs and inverted Ts, is completely normal. If I told you this was a 65-year-old patient with some symptoms, it wouldn't be normal. They'd have LVH and they'd have inverted Ts. but I'm guessing this is just a child's EKG, and it's completely normal. So if you got that, you are reading the age now of an EKG. That's awesome. Okay, let's do this one. Do I have anything on this one? One in AVL? Anything going on weird? I don't really see a T wave there. It's kind of flat. 2-3 in AVF. It looks pretty normal too. The T wave is a little flat. V1. That T wave doesn't look normal. That T wave is inverted in V1. The T wave is inverted. But do we have any other T waves that are inverted? Anteriorly? No. So that means it's, what's the word? Non-diagnostic. If you only have one lead in that area that has a change, it's non-diagnostic. So that inverted T is non-diagnostic. Okay, we do see definitely some big QRSs, which typically mean LVH, right? Whether this is good LVH or bad LVH, we don't know because we don't know the age of this patient. We can probably guess the age though. I could probably guess, I'm guessing this is a female, but not young, probably 40s or 50s, because we have one inverted T wave in V1 that's just normal for them, but they have chronic high blood pressure probably because they have really big QRSs. I don't see any other changes. There is a small little change here in V6, but it's non-diagnostic again. The T waves are not peaked enough to be considered peaked. They're not more than 2 boxes high, so those are not peak Ts. Only thing I see really is LVH. Did you get that? Awesome. All right, I believe this might be our last one. I believe it is our last one. Yes. Okay, so let's do one in AVL. We'll wrap this puppy up. One in AVL. Looks completely normal to me. 2-3 in AVF. There are some changes there. You see them? This actually looks a little elevated, but what I'm more concerned about is this inverted T wave here and inverted T wave here. I don't see much of a change here. It might be an inverted T, but it's not complete. So I see change in 3 in AVF, which means we do have a change inferiorly, and it's just inverted and slightly inverted. So it's not scary inverted, but something to look into. Over here, however, V1, V2, V3, look at that T wave. Look how deeply inverted that T wave is. Okay? So this can be a recent MI, or it can mean we can worry about deep ischemia. We can also worry about a pulmonary embolism when we see deeply inverted T's. So remember that thing we did, Q1, S3, T3? We'll go back and do that in a moment, okay? But let's take a look over here. We have another inverted T, and these are okay. So there's something going on anteriorly, and because it's anterior, this deeply inverted T wave is anterior. It makes me think it might be a pulmonary embolism. So I'm going to go back over and check that Q1, S3, T3. So Q1 means the Q wave in lead 1 is probably deep and big. And look at that, it is. I'm sorry, the S wave. S wave is big. I got it backwards. S1, Q3, T3. So S wave. So this is our QRS, and the S is deep. That checks out, doesn't it? Let's go to lead 3. So Q wave in lead 3 should be big. Here's our Q wave. It is big. And then we should see a T wave inversion in lead 3, which we have a T wave inversion. So this checks out as a pulmonary embolism. And what gives it away the most is these three here, the S1, Q3, T3, but also that he has this deep T wave inversions in V1, 2, and 3. This is almost gives it away that's a pulmonary embolism. All right? All right, that's what I have for you today. That is it, my friends. That is it. So for today, once you finish the notes, you do have an assignment to practice everything we learned last week and this week all in one. So it's ischemia infarction practice on D2L, and have that done by next class. That is the only thing you have to have done by next class. And we're going to review next class over Zoom next week, and then you'll have a test next week. All right, send me a message if you have any questions. Keep being awesome. You guys are great. I will see you soon.